Welcome to this explainer for The Skin Surgeon, where we're going to cover a topic that, let's be honest, drives a whole lot of late-night internet anxiety. We're talking about stubborn rashes and a very rare skin lymphoma known as Mycosis Fungoides. Now, before we really get going, I need to mention that this presentation was prepared by Dr. Thomas Hocker. He's a Harvard and Mayo Clinic-trained, triple board-certified dermatologist, Mohs surgeon, and dermatopathologist, so he really knows his stuff. This explainer reflects his expertise and was reviewed for up-to-date accuracy as of July 3rd, 2026. Also, just a quick reminder, this is for general education, not personal medical advice, and it doesn't establish a doctor-patient relationship. You should absolutely always talk with your own clinician about your health. All right, with that out of the way, let's dive right into this. If you've been dealing with a rash that just will not quit, you've probably Googled it. And, well, if you've Googled it, you've probably terrified yourself. The internet has this really unique way of taking a simple itch and turning it into an immediate worst-case scenario. So let's just answer the question you're actually asking right now. Is every stubborn rash cancer? Let me give you the short, calming answer right out of the gate. No, absolutely not. In fact, let's go ahead and bust our very first myth. The internet will try to tell you that if a rash won't go away, it's probably cancer. But the real fact here? The overwhelming majority of persistent rashes are common, completely benign inflammatory issues. We're talking about things like eczema, psoriasis, or contact dermatitis. Sure, these conditions can be incredibly frustrating, and they can be stubborn as a mule, but they are not cancerous. What's really fascinating is just how rare this specific cancer actually is. Mycosis fungoides affects roughly 3 to 6 people per million per year in the United States. To put that into perspective for you, eczema and psoriasis are roughly 1,000 to 10,000 times more common. We are quite literally talking about finding a needle in a haystack. But, because that needle is real, we need to understand what it looks like so we can practice calm vigilance, not panic. Section 1. What is it? Mycosis fungoides. Okay, so the crucial takeaway is right here in the definition. Mycosis fungoides is a rare cutaneous T-cell lymphoma, or CTCL for short. Basically, that means it's a cancer of the immune system, specifically your T-cells, that primarily lives right there in the skin. But take a look at that second bullet point. It is not a fungal infection. I know, the name is incredibly confusing, right? It actually dates all the way back to 1806 when a French doctor thought the skin tumors in a historical case looked kind of like mushrooms. The name stuck, but the disease has absolutely nothing to do with a fungus, and it is entirely non-contagious. Now, hearing the word lymphoma understandably causes a lot of fear. It's a scary word, but let's bust another major myth right now. The myth is that this diagnosis is an automatic death sentence. The actual fact? Early-stage mycosis fungoides behaves very, very differently from the aggressive lymphomas most people picture. A lot of people are diagnosed early, and for stage 1A, the 5-year survival rate is a massive 95 to 96%. In fact, most people with early-stage disease live a totally normal or near-normal lifespan and ultimately pass away from entirely unrelated causes. Mycosis fungoides generally progresses through stages, though it's important to note that not everyone goes through all of them. It usually starts out as patches. These are flat, scaly spots that can look basically identical to eczema or just regular dry skin. Over time, those can thicken up into plaques, which are raised, firmer, and often pretty itchy. The final stage involves tumors, which are these dome-shaped lumps. Because those early patches look so remarkably ordinary, the disease can easily hide in plain sight for years. And that brings us to an absolutely crucial medical nuance. Mycosis fungoides doesn't always show up as pink or red patches. On darker skin tones, it very often presents as hypopigmented, meaning lighter, patches, or sometimes hyperpigmented, darker patches. Actually, the lighter patches are the most common form seen in Black patients and in children, and it can closely mimic a condition called vitiligo. Recognizing this is just so vital for equity in healthcare, because, if clinicians are only looking for red patches, the disease can easily be completely missed in patients with darker skin. Section 2. Diagnostic Myths. Uncovering the Truth. I really love this analogy from our source material. Diagnosing this condition early on is exactly like fishing. The abnormal T cells in early-stage disease are super sparse. They're basically hiding out amongst a massive sea of completely normal inflammation. A biopsy is just a tiny, tiny sample of skin. So if your doctor takes a biopsy and doesn't manage to catch those specific abnormal cells, they might just see normal inflammation under the microscope. Which leads us directly to this massive myth. A normal biopsy definitely rules it out. The real fact here is that the very first biopsy is diagnostic only about 25% of the time when the disease is actually present. So if your doctor strongly suspects Mycosis fungoides, but that first biopsy is inconclusive, asking for a repeat biopsy from a different spot later on isn't a sign that your doctor messed up. It's actually standard medical practice for dealing with this specific elusive disease. All right, here is another diagnostic myth we really need to clear up. People so often think, well, my blood work came back completely normal, so there's no way I have lymphoma. The fact is, early Mycosis fungoides is a skin-only disease. The abnormal cells just haven't entered the bloodstream in any significant numbers yet. So having perfectly normal lab results is exactly what doctors expect to find in the early stages. Section 3, Treatment Ladder. Gentle approach first. When it comes to treatment, this is the overarching philosophy you really need to remember. Gentle first, escalate only if needed. Doctors do not want to attack an early-stage, slow-moving skin disease with their biggest, heaviest weapons. Multi-drug systemic chemotherapy is generally not the first-line approach for early Mycosis fungoides. In fact, research shows it can actually cause more harm than good if it's used too early in the process. Instead of harsh systemic treatments, they use what we call skin-directed therapies. This really highlights just how targeted the approach is. Treatments usually include things like potent prescription steroid creams, specialized narrowband UVB medical light therapy, topical gels that you apply directly to the lesions, or maybe some localized radiation if there are just a few stubborn spots. The whole goal is to control the disease and keep your quality of life high using the absolute gentlest effective options. And hey, speaking of light therapy, we absolutely have to debunk a really dangerous myth right now. Some people hear UV light therapy and immediately think going to a commercial tanning bed is a valid do-it-yourself treatment. It is absolutely not. Medical phototherapy uses precisely calibrated, safe wavelengths under strict medical supervision. Tanning beds just deliver uncontrolled UV exposure, they do not effectively treat the disease, and they aggressively increase your risk of other skin cancers like melanoma. Never, ever substitute a tanning bed for real medical care. Section 4, Red Flags and Steps. When to see a doctor. Okay, we've covered a lot of ground today. If you have a rash right now, here is your practical red flag checklist. Keep an eye out for a rash that lasts for months or even years. Notice if it heavily favors areas the sun rarely ever sees, like your buttocks, your inner thighs, or under your breasts. Pay attention if the patches are odd, varying widely in size and shape, or if the skin starts looking mottled and crinkled. But honestly, the biggest red flag of all, it's a rash that temporarily gets better when you use standard creams, but then stubbornly keeps returning the absolute second you stop. If any of that sounds like you, it is time to step away from the internet and book a visit with a board-certified dermatologist. And when you go to that appointment, arm yourself with these exact questions. Ask them, was my biopsy reviewed by an expert in cutaneous lymphoma? Ask, should I pause my topical steroid creams for a few weeks before a repeat biopsy? Because remember, those creams can actually hide the diagnostic clues the doctor is looking for. And please, don't be afraid to ask if you need a referral to a specialized center. So, what does this all mean for us? The real crucial takeaway here is calm vigilance. Remember, most rashes are just rashes, but a rash that absolutely refuses to act like a normal rash deserves a proper diagnosis. So, are you ready to close those dozen browser tabs, stop the late-night sleuthing, and finally partner with a dermatologist to get a real answer? I really hope this explainer has helped replace some of that fear with understanding and given you the confidence and the tools to take that next practical step. Thanks so much for joining me today.